Okay, we're going to go ahead and get started. Just initially, thank you for coming tonight. On behalf of all of the members of the Farmington Area Suicide Prevention Task Force, really this is all about the community and seeing the community members here. That's the important thing. It's about getting information into your hands. Our task force, I'm going to talk my job. My name is Ken Massey. I am one of the co-chairs of the Suicide Prevention Task Force, and I am also on your city council. And it is my pleasure to kick us off this evening with a little bit just in terms of what is the issue, frame it, and then we have a number of interesting speakers who will come up and present, and then that will be followed by a question and answer period. So as you can see, our logo here, the Suicide Prevention Task Force, the mantra is, let's talk about it. That's going to come up several times during this evening. So talk about what? Well, initially, the discussion is to talk about suicide. The reason we need to talk about it tends to be a taboo subject, as was cancer 35 years ago. There are a number of these issues, but now we all know what risk factors are for cancer. We know what risk factors are for heart disease and so forth. We also know that suicide has risk factors associated with it. But many people don't know what those are. They don't know what that picture is, and we can't get information into people's hands if we can't have that conversation. So we're going to break that taboo, and that's what we're talking about. What is the scope of the problem? Okay? The scope of the problem is large. And just to kind of put a number around it, put your head around it, in the United States, we have 38,000 suicides a year. Think about that for a moment. That's a big number. 38,000 would equate to a jet airliner with 300 people on it going down every other week during a year. If that was occurring, number one, would you be going on vacation or on a business trip on a plane? Probably not. But we would be crying out to find out what's causing it. But we're not. If you had someone who was a child predator who was trying to abduct a child in our community, our police department would be out in force, our first responders would be out there trying to find that individual. Well, 16,000 of those 38 are our youth. They're being taken from us. And right now, if we can't talk about why, we'll never get to the reason. Another way of looking at that is 38,000 a year equates to 1 every 13.8 minutes. You have one suicide every 13.8 minutes. That means that every 14 minutes you have a family left asking the question, why? It's a major health challenge. This is a normalized graph going from 1987 to 2010, the last year that we have, that the CDC has actual full year information. And as you can see, this is the suicide rate per 100,000 of our citizens. What's the problem with that graph? Look at it from 2000, the middle of the graph, going to the right. It's increasing, and it's increasing every year. This slide, to violate every presentation rule there is a slide that you can't read. But what this is by age group, across the top, the 10 leading causes of death of our citizens by age group. And if I was to point out this age group right here, 15 to 24-year-olds, you'll see the green box is the suicide rate. It is the number 3 cause of death, just behind homicides, for our youth between 15 and 24. I will also tell you that after 24, from 24 to 30, or 25 to 34, it increases to the second leading cause of death. So this is not something that you get over. So the question becomes, have you been touched? And I could ask this question, and by a show of hands, how many people have known somebody or lost somebody, but I know that it touches every race, every economic status, touches every type of employment, every type of education, educational level. Sexes, religions, you name it, everyone is a potential suicide victim. And every family, suicide survivors. And chances are, though, that unless you've been touched, most people think they're immune. And you think it's not going to happen in your family. My family's happy. My kids are happy. My friends, you know, until you get a phone call and you find out, like we did when my wife and I got our phone call. So I understand the pain of being on the survivor side. And to a person I've spoken to, it starts out, we didn't know. Well, we're trying to change that with our Farmington Area Suicide Prevention Task Force work. That's why we're here. The beginnings of this started back in about May of 2010 when two other of my city council colleagues, Nancy Bates, Dr. Randy Bruce, noticed something on one of our police reports. We saw too large a number of our youth that were attempting or actually threatening or actually attempting suicide. We came together and we studied the issue, thinking naively that maybe we didn't have enough resources. Well, this community has resources, and that's what we've seen out here on this table. The tables out here, our various resources. We also thought, well, you know, what is it then? What we found out is nobody's talking about it. How do you put the people together who need it with the resources that are there? Well, you have to overcome the denial. You have to overcome that we don't know what the symptoms are. You have to then destigmatize asking for help. There is no problem in asking people for assistance with mental illness. It's just like diabetes. It's just like cancer. You get out there, you get that person diagnosed, you get them help, and we can save people to do that. We're doing it through awareness and information. We started out with a very large awareness session in this chamber, and now we're into the topical, trying to drill down on specific issues. And with tonight, it's that link between mental illness, suicide, and the influences of substance use/abuse. So who are the members of the Farmington Area Suicide Prevention Task Force? They're community members. They're public liaisons from our public safety side. They're members of our school district. They're mental health professionals. They're common ground members. They're advocacy group members. We have youth members because we're trying to reach the youth, so we had to ask them. So we have, now I'm proud to say we have 4 of our high school kids that are on our Farmington Area Suicide Prevention Task Force. And would the members of the task force who are here please stand up to be recognized? These people put in a lot of work to put these programs on, and they deserve a round of applause. First, we were meeting every 2 weeks, and we finally got it down to a monthly meeting to plan these. So, but all this work is done with the idea that we can save a life. We do it through resources, printed materials, public educational, government programming. We do community conversations like the one tonight. This is just a list of some of the things that we've had in the past: preventing suicide in LGBT youth, the internet and mental health. Tonight's on substance abuse. We're planning currently, upcoming topics will be abusive relationships, surviving an attempt, which was a suggestion by one of the attendees. So we have a number of these coming. Our plan is to do them every 3 or 4 months for the community. On this is the list of these signs and symptoms of somebody who may be at risk. I'm not going to go through this entire list tonight. You're going to hear other things about it, and I hope you picked up a magnet. There are refrigerator magnets. One of the things that we're thinking of, if we can give everybody this list, you put that on your refrigerator, you look at that, somebody is at risk when they have a number of those, or they're extreme, or they're lasting for more than a couple of days. So please take a look at that, take one home, put them up there, and remember there's no stigma in asking the difficult questions and getting those people assistance. Our efforts are supported by our other members of our city council. In fact, we just passed a resolution, this is just the title of it, that went to our governor and to our state legislatures, to key legislators, asking to revamp and improve our mental health assistance network. It's been decimated over time, and we need to stop using jails as places that we get people assistance. We also have, in addition to the support from the Farmington and Farmington Hills City Councils, Farmington schools, business sectors have stepped up and assisted us, people like yourselves who are here. One of the things that we do is we do nothing with public money. This is all done through either volunteer efforts or donations, and there's a little black box over there. But to let you know, it's the Graham Smith Memorial Fund for Suicide Prevention, and this is named for my stepson who died in May of 2011. It can also be donated, and this is a 501c3, so all your donations are tax deductible, and that's what we're using, that's the mechanism we use to support this work. So take away the messages that in a community that cares, we can make a difference. If we know there's an issue, if we have the information, if we know what to look for, if we have the courage to answer those challenging questions, and we know what to do with the information. To get any of those things, we have to talk about it. So those conclude my remarks. Just you'll hear more about the local situation as the other speakers present that, but I would like to now turn over the podium to our first speaker, Dr. Ryan Blackstock, and I'm going to load his presentation up here. And I hope you find the evening very enjoyable. Oh, I should also mention that one of the resources out here with the Dr. Paws, these are dogs that go into our hospital emergency room into Botsford and work with people who are ill or have attempted, and these are therapy dogs. So we added them in as a resource today, and we're really glad that they're here. So that's the service animals that you're seeing. So Ryan, thanks for coming.
Okay, thank you. All right, thank you. I am Dr. Ryan Blackstock, humanistic clinical psychologist. I work full-time at the Michigan School of Professional Psychology. I hold, as you see up there, a lot more letters almost behind my name than in them, right? But the doctorate, the license, and then the advanced addiction credential, which is national, and then the I just is the international version. I've been doing substance abuse treatment for more than 20 years, and many of my places that I've worked in included adolescent units in all varieties, really, everything from inpatient to outpatient to residential living, a converted apartment complex where kids could stay for up to 9 months if they were working. And so what I'd like to present to you tonight is information about substance use, abuse, how we classify it, so you get a better understanding, and maybe we'll break some stigmas along the way about what is use, what is abuse, what is dependence or addiction. And then I want to tie it into research, some of it within the last 10 years, some of it last year from U of M, about the relationship between substance use and then mood disorders. So mood disorders, we only have 3 in our diagnostic criteria, which is major depression, dysthymia, a long-lasting, milder depression, and then bipolar disorder, which includes mania and then a depressive episode. So what they all have in common is that they're going to look at the symptoms of depression. One of the 9 symptoms is what? Thoughts of suicide, okay? So at the end, I want to tie that together, give you some statistics, and then talk about, so what do you do? And I brought some handouts towards the end that will give you some crisis intervention numbers for either side, mental health, substance abuse, and some ideas of where you can go from there. Okay, so I want to regress to about the summer of 1975. And let's talk about, before we talk about why adolescents drink and use drugs, let's just use alcohol. Why do adults use alcohol? And Father Joseph Martin, who went on to be a renowned public speaker in the recovering community, said that really we have 3 reasons why adults drink alcohol. That there's curiosity, there's custom, and conviviality. Curiosity, in terms of social expectations, we're not allowed to drink until we reach a certain age. And so there is a lot of curiosity about what is this, he would say, this magic elixir that adults get to experience. And so, early on, you take a little alcohol, you put some sugar in it to make it sweet, you put something in it to give it a little color, and you drink it, and you're doing just what the adults do, just what big people do, from the mind of an adolescent. It's curious, what is this thing, and think about all the commercials you see about alcohol and what alcohol does for you. Being in addiction treatment for many years, I have yet to see a commercial for, I'll just say Budweiser or any of the liquors that shows, oh, you're in detox, or why you wound up in jail, and you're picking up garbage on the side of the road, and you lose your license, or any of the negative consequences. Our media shows you'll be the life of the party, you'll have creativity, you'll have sexual prowess, you'll be funny. And so there's a lot of curiosity about, why aren't we allowed to have this thing that leads towards use? And when I say use, I don't mean addiction necessarily, but just why do people want to try drugs? Why do they want to try alcohol? There it is. Custom. In our Western culture, there are lots of days and events where drinking is expected or considered okay. And if we went through the holidays, we have a couple holidays every year where there's lots of drinking. Knowing from getting court referrals, I get a lot of referrals right after New Year's Eve, okay? A lot of them right after July 4th, and then along the way, and holidays or where there are events that drinking is sanctioned, okay? And not alcoholic drinking, just drinking, people are exposed to that. So, the list could be on what days do normal people drink, and we could throw out the list of holidays, feast days, fast days, holy days, births, deaths, weddings, graduations, and then when you get to my alcoholic clientele, Mondays, Tuesdays, Wednesdays, Thursdays, Fridays. But alcohol is prevalent, and they said that when the Nina, the Pinta, and the Santa Maria came over, they were stocked 2/3 with liquor because that's the substance that would stay good on an overseas voyage. And then conviviality. And conviviality is just this essence of lightheartedness, spiritedness. It's hard to put it into a sentence, but to explain conviviality, there's a lot of conviviality that goes on with drinking. Okay, again, commercials, that's what they're playing to. Look how good of an experience this is going to be. When you compare the conviviality that alcohol has compared to, say, root beer, okay, one glass of alcohol does what all the root beer in the world can, right? It begins to make you feel good. It changes the way you feel. It changes the way, maybe you have some root beer fans, but it changes the way you feel. It changes the way you think. It affects the brain in different ways, and it produces, at least usually in the early stages, this sense of well-being, of, we would say relief drinking, but someone had a long week. Okay, well, it's Friday, I've earned it, I deserve it, or I just paid the taxes, or, and eventually it'll devolve to, my sports team won, my sports team lost, it rained, it didn't rain. I mean, the reasons begin to stack up, the alibi system. It's not so different with adolescents. They're curious about it, and it's this thing that's, oh, it's taboo. You shouldn't, ever do this. And sometimes I think the stigma is, the second you try any drugs, bad things will happen to you. You'll go to jail. Where statistically, it's not, evident the first time someone tries. They get high and, oh, well, wow, I'm not in trouble, and this is just a different experience of consciousness. It becomes customary, okay? When a young person discovers the effects of drugs, it can become customary. If you're around young people, you'll know this number, 420. Okay, do people know that? 420 is the time, each day, if you're a marijuana smoker, to smoke pot to get high. It's, and the date, okay, so April 20th is double 420. And it produces a sense of we're doing this together, especially with drinking or illicit drug use. That's the one thing about, I'll say, the addicted community, or if we were to just break kids up into groups, think about the cliques that you had in high school, okay? What kind of groups did we have? We had the what? Jocks. Okay, burnouts, we'll come back to them. The nerds or the brains, the pretty girls, the cheerleaders, the tough crowd. In most of the cliques, there's some, or I would say preppies, the kids that had the expensive clothes, there's some qualification to join that group. If you're a jock, you need to be good at a sport. Okay, if you're in the preppy crowd, you need to have whatever the most fashionable clothes are. If you're in, the nerds, you probably need to be really good at math, enjoy chess. I mean, there's some qualifications. But what happens in the drug crowd is, you want to guess what the qualification is there? Money, time, access. Okay. Yeah, I would say that it's not necessarily failing grades in the beginning. In order to hang out with the drug users, you just need to have money or drugs or a space to use them at or something you can sell, trade, etc. It's the easiest access group, okay, because there aren't any other requirements. So when I talk about drug use, I'm going to say there's experimentation, abuse, and dependency. And we're going to spend most of the time talking about the difference between abuse and dependency. But experimentation is simply a period of time where there are either no consequences, or if there are consequences, it tends to cease use right away. Someone may have a bad experience. Clients will say, oh, well, I tried smoking pot and it made me paranoid and that was it. That would be a case for experimentation, just one negative experience and they don't do it anymore. Or they fantasized that this drink was going to taste really good and they drank a lot of it and then got really sick and then realized, yeah, I don't want to do that again. That would be experimentation or use. And what we have to understand is that in terms of treatment, most people who choose, let's just stick with alcohol for a little bit, choose to drink what I say successfully, without having any major consequences, without developing tolerance, withdrawal, and the features we're going to get to. But when we cross these lines from experimentation or use into abuse, there are changes which in the beginning will be external, and I'll show you those, and then later on they become biological and psychological in nature. So I said, what should the frequency be in terms of use? Well, theoretically, we should say, well, no adolescent should be drinking and they shouldn't be using drugs, so the symbol here should be 0. But that's clearly not the case with the research. So when we look at, as a clinician, how do we qualify, is this abnormal drinking? Is this problem drinking? I mean, the easy one is that if it's causing trouble, it's a problem. But the 4 criteria we look at, and it can be any or all, is does the use result in danger? Does it cause distress, or other people will say discomfort? Do people say, I drink or I use even though I didn't mean to, I didn't want to, and yet it happened again? I promised I wouldn't, do it this time, and here I am. Does it cause dysfunction? And that's one that we'll look at. What areas does it cause dysfunction? And I'm going to argue, eventually, all of them. And then when I say deviance, I just mean, does it go beyond what is the social norm? Now, typically, and I've had adolescent or young adult clients that, will tell you that they will drink a fifth of liquor in a setting. That is what? Abnormal. Adults don't do that. Okay, normal people don't do that. But the facet of tolerance, when you build up a resistance where it takes more and more of the chemical to get the same effect, that's what deviant. Normal drinkers don't tend to get that. Okay, so these are big, long definitions, but I'll make them simple. When we talk about abuse, we're only looking at a 12-month period of time, so the last year. So if you had a young person in your life and you go, I wonder if they have an abuse problem, and they just say abuse, you insert whatever the drug is. So it doesn't matter if it's alcohol abuse or cannabis abuse or cocaine abuse or sedative abuse, anxiolytic, anti-anxiety medication abuse. Abuse is abuse. It's not distinct per drug. All the drugs have the same criteria in abuse and dependency. So we're looking at a pattern within a year's period of time of, the key thing I put in bold is recurrency. Recurrency simply means, so we don't put a number on it, but it's the beginning of a pattern. Okay? Because if any of these things happened once and there was a change in behavior, we'd say, okay, that maybe fits experimentation. Okay? But when it's happened, if you had to put a number 2 or 3, and this is becoming, a habit, a pattern, we've gone through this, that's what I hear from parents, we've gone through this over and over, then at least we're looking at abuse. So we look at abuse in 4 areas, and they're all pretty much external to the person. So look at the places that they are involved with. The first one is, it says recurrent substance use resulting in failure to fulfill major role obligations at work, home, or school. And that's often an adolescent's life, right? If they have a job, does it cause problems there? Is it cause problems in the school system, or with major role obligations at home? Now, that's probably smaller as adolescent as compared to an adult, but are they having trouble, keeping promises, doing chores? Taking care of responsibilities. Your major obligation at school is to show up, be present, not have any discipline problems, turn your homework in. These are the simple things we expect. So if there are recurrent problems in those areas related to drug use, all you need is one of these 4. That's an abuse criteria. 2 just says use in situations where it's physically hazardous. Now, the top 2 by the manual is driving a car and operating heavy machinery. Teenagers drive cars, probably not as many operate heavy machinery, but we have to think outside the box. What other activities do adolescents participate in that it would be hazardous for them to be intoxicated or high? Yeah, sports, skateboarding, swimming. You could expand this list. Yeah, big. Driving a car, or riding in a car with someone else who is impaired. That fits in the criteria because that's hazardous. Because we don't know if that person is in control of their faculties, if they're safe. So we're going to look outside of just drinking and driving. Do they participate in, I say extreme sports, etc., skiing, that sort of thing? And are they getting high? Is this causing? It just says there don't have to be problems because of that. If you take that level of risk, then it's an abuse problem. The other 2 says, well, okay, when you start racking up substance-related legal problems, that's a hallmark for abuse. Now, it's easy to go, oh, well, you must mean, a minor in possession or possession of alcohol, drugs. But if someone is, committing, and I'm not fluent on all the terms legally, but committing destruction of property, or maybe it's malicious destruction of property, vandalism, getting in fights, assault, etc., those could be legal problems. Or if they're acting out and it's causing, people to say, well, the homeowners association is not happy with your parents because of your child's behavior, that would fit. And then 4 is continued use despite having basically social or interpersonal problems that are either caused by drug use or made worse. And that's where you tend to see family problems the most. Or loss of friends, change of friends, etc. So it says that, they have the knowledge that this is causing problems, and yet they do it anyway. That's a hallmark for abuse. And that's the whole criteria, that if they have any one of those 4 within the last 12 months, you've got someone who has an abuse problem. Now, that's not addiction, okay? That's not an alcoholic. But your interventions are going to be about the same in the beginning, that this person needs to be stabilized. You'll have to do a couple things, and we'll get to that later. But at this point, and this is where a lot of work with adolescent occurs, is they've experimented, they're starting to have consequences. It comes to the school's attention, the parents' attention, someone's attention, and then they come to therapy, and we go, oh, okay, well, what's going wrong in your life? Let's look at the common denominator. And sometimes it's, the parents go, well, of course it's their friends. Well, yeah, it's their friends, but it's also their choice to be around the friends that are doing these things and other issues. On the other side, when we talk about substance dependence, okay, and we have a lot of terms for this. We call it alcoholism, drug addiction, chemical dependency, just general addiction, drug addiction. When I say that, alcohol is a drug, so I'm including that in there. What we're looking at is this is a different ballpark. Now, it's not just a minor problem. Maybe abuse doesn't feel minor, but in the scope of addiction, which often results in death, abuse is the one I'd rather treat on any given day. So it says within the same 1 year period, we're going to need 3 symptoms. And that, what does it say? Because we have to incorporate that many kids are using other people's prescription drugs. So using drugs that are not prescribed to them, using them even if they are in inappropriate amounts, or basically not following directions. That if you're prescribed your Adderall for this, you need to take it as it says on the bottle. Not experiment with, well, I wonder what this would be like. What if I mix it with this? What if I cut it? There are all sorts of things that teenagers do. So the first one, and I mentioned this earlier, is tolerance. Now, essentially, the human body develops tolerance on its own. Anyone that either has smoked cigarettes in the past or drinks caffeine, coffee, develops some tolerance. Okay, think about your first experience with coffee. Does anyone remember that? Your first cup of coffee? No, you don't remember that? I've been privileged to see a client have their first cup of coffee, and he had a 4-ounce cup and was wired and jittery and all over the place. But after a while, people are drinking the venti Starbucks things and then they could drink that and go to bed. Okay, that's tolerance. Or they could drink a couple in the course of a day. So the human body develops tolerance. I mean, that's one of the reasons we don't have over-the-counter antibiotics, because if we built a tolerance to it and then got really sick, there wouldn't be anything to treat us with. So tolerance can't be the only thing. Now, in working with addicts, again, their tolerance builds up to where they can use amounts, even if we say alcohol, they drink a lot more alcohol, where if I took a normal person off the street and they drank what you drank, what would happen? And oh yeah, they would be out. They might die. Okay, that's tolerance. So you can measure it either by the need to do more to get the same effect, or it's really pretty rare. If they use the same amount but say, oh, I never drink more than 3 beers, but 3 beers don't do anything for me anymore, that's tolerance. The other side of that is withdrawal. Withdrawal symptoms, that's probably another discussion, but shortly, whatever the drug does, withdrawal neurologically looks the opposite. So alcohol being a sedative drug, when you go into alcohol withdrawal, you have agitative effects that people have tremors, risk of high blood pressure, stroke, seizure are all very high in that 72 to 96 hour detox period. So another sign of dependence is if you have withdrawal symptoms or you use to avoid withdrawal symptoms, that's a point towards dependency. And those are the only 2 physical signs of addiction. Addiction dependence doesn't have anything to do necessarily with how much they use or if they drink the good stuff versus the cheap stuff. If they're doing heroin versus smoking pot. We don't make any distinction across the drugs. We look at the consequences. So your physical side, it doesn't mean you have to use every day to be an alcoholic or an addict. There are plenty of people that binge use but still develop tolerance and withdrawal symptoms. The rest of these, the symptoms are psychological, changes within the thinking of the individual. And that's maybe the hardest part to treat. So number 3, that whatever they're using, they're taking in larger amounts or over a longer period of time than they intended. Now think about when we intend to do something, we would say what? What would be another way to say that? Like I intend to go home and this weekend I'm gonna, do some yard work. What am I saying? I plan on it. I'm going to set my will that this is going to happen. Like, hey, on the weekend, as long as it's not snowing, I'm going to get out there and take care of the yard. So the third criteria says, despite someone's intention to not use or to only have one, or boy, I'm on probation and yeah, I'm going to stay clean for this whole duration. I'm not going to touch anything. 2 weeks later, they come up in a urine test dirty. They intended to not violate probation, and yet, it happened. That the addiction is trumping, their intentions. If we argue about willpower, now I need to throw willpower out in terms of the addiction side. That if addiction treatment was really about willpower, I'd be out of business. There wouldn't be any alcoholics because no one sets out to be an alcoholic. No one intends on being a drug addict. When you're in high school, you think about meeting with a guidance counselor. They go over, so what would you like to be? A doctor, a lawyer, an EMT, a police officer. Like they never screen you. Would you like to be an alcoholic? Would you like to end up as a drug addict? That's not on the horizon. But it happens, and it happens in a good percentage of the population. 2 is when people, they begin to think, maybe I need to do something about this. They realize that, boy, this is getting out of control. They either have this desire to cut down, or they have attempts of quitting, and maybe the attempt of quitting is, that's it, that's the last time, and they might make it a week or 2 weeks or a month, but then they come back to it. Despite what their intention, again, that's what being out of control. 5 depends on the drug. That for adults, alcohol, you don't usually have to spend a great deal of time finding it, right? But they might spend a great deal of time using it or recovering from the effects. When you get into illegal drugs, it depends on where someone has to go. If they have to drive from Farmington Hills to Lincoln Park and wait in a parking lot for a drug dealer to come by, make an exchange, that may start to qualify for part 5. 6 bounces on abuse. Abuse said major role obligations in work, school, home, the legal system, physically hazardous situations, and then relationships, friends, social and interpersonal, family, siblings, etc. 6 says, important social, occupational, or recreational activities are given up or reduced because of substance use. So some of this would account in adolescence for dropout rates in high school, running away from home, if they have jobs, they lose their jobs, or they can't get a job because they can't pass the pre-employment, drug test. And what you see, and really one of the saddest things, is that I've worked with plenty of people over the years that were just amazingly talented individuals. And in the beginning, the alcohol or drug use was just, it was just part of being one of the guys, being one of the gang. And then over the years, they separate, and the alcohol and the drugs went out. That they drop out of their sports or their hobbies, etc., because using begins to take up what more and more, time, both internally and externally. And then the last one is just, again, if you use despite knowledge of having a physical or psychological problem that's caused or made worse by using, really, if you use and you know better, then that's a point for dependence. Now, you only need 3 of that 7 to qualify for dependence. Typically, when I see clients, they get most of them, okay, 5 or 6, fairly easy, even in adolescence, okay, when addiction progresses that far, because it doesn't take 20 or 30 years to become an alcoholic or an addict. It can happen in a relatively short period of time within, you could have it happen in 6 months, depending on the progression of use, a year or 2. Okay, so how does this tie into mental health and other disorders? Well, and the idea I came up with is we should talk about what came first, the chicken or the egg. Is it the substance abuse that leads to depression, that leads to suicide, or is it depression, or any a number of mood disorders or basic disorders that leads to what we call self-medicating, using to control that leads to suicide? And I came up with, like psychology does, two or more answers, right? In some ways, in terms of treatment, it doesn't matter. That if you have a person suffering, and people suffer that are in addiction, although on the outsiders, it looks like they're having all they're doing is getting high, and the family is suffering, that person is suffering. Or if it's mental health, I think people are much more compassionate in terms of the mental health issue. Someone is very depressed, very anxious, etc. The person needs treatment. So to me, it doesn't matter which came first. We need to treat both issues. And in some ways, I want to know what happened first, because if it's substance use, I say abuse, dependence, etc., and the consequences of the use have led to depression, then probably if we rectify, we take away the use and we give them something else. We give them a program of recovery and some structure or a cause, etc. Then some of the depression and the anxiety will resolve itself over the next 6 months to a year probably. If it's the other way around, then we need to have more effective ways of them managing and treating their depression and anxiety, okay, instead of turning to drugs or alcohol. And some people are taking psychiatric meds, and then they drink or use on top of them, which often defeats the purpose. If you're using a drug, a prescribed drug, to say your mood, okay, we want to keep it here, and then you inject something else into the system that puts you up or down, you've shot yourself in the foot. You've defeated the purpose. So this study here, I just wanted to throw a few graphs your ways to look at marijuana use of 12th graders, and this is a 2012 U of M study. They tracked it over the years, and what they found is that when the use of marijuana, which is maybe the most frequent used drug in adolescence, when it's perceived that that's dangerous or that there's risk involved, statistically, the rates of use are lower. Where when it's not perceived as risky, when it's perceived as cool, socially acceptable, etc., you see that rates of use are high. And the only exception here would happen to be in the late 80s to early 90s. I didn't get to look at the core data here, but if I had to take a guess, I put 3 things on my list. One, even though maybe in terms of the long-range statistics, the war on drugs, people say it didn't work so well. This chart might say otherwise, that it affected some people. Now, these are not necessarily addicts that we're talking about. These are just people that admitted to using marijuana. You can have that around this time, stiffer penalties for what? Drug convictions, possession comes into play, like mandatory sentencing, etc. That might have been, oh, well, that's more of a risk. Like I might smoke pot, but I don't want to go to jail or prison over it. And in some cases, and this would be more on the local level, people might be lacing marijuana with things. People have bad experiences, etc. And that happens with trends of drugs over time. I work in I was practicing in the Downriver area, and a few years ago there was a bunch of bad methamphetamine. Okay, and suddenly methamphetamine use dropped, but then what? Heroin went up. So drugs tend to have trends, but the higher the perceived risk of using a drug, the lower incidence. And then the same 12th grade population, and this was within the continental United States, what we find is that among 12th graders, they admit about a third of them have tried marijuana or hash, and then it goes down and down and down. But what you see is after we get past marijuana and synthetic marijuana, Kush, there's a bunch of street names for it, then we have what? Adderall, so ADHD medications, Vicodin, pain medications, cough medicine, and then tranquilizers. So you could, probably in tranquilizers, we could throw Xanax in there, anti-anxiety medications. And then the rates go down, for other drugs. But marijuana is still like the number one. So the data from U of M study just says marijuana use is on the rise with teens, and most teens in these surveys that were done nationally more teens admit to smoking marijuana than trying cigarettes. Also, the thing that's on the rise is the hookah, water pipes, small cigars. Those are increasing. 14.8% last year of the high school students surveyed used a prescription drug for non-medical reasons. They tried it. And what would it be like? Will Adderall help me do better on a test? I'm stressed out, or I'm hurt from football practice. Will this help me perform better? And binge drinking happens. I guess I've worked with enough adolescents where even though we think, theoretically you shouldn't be able to get alcohol, they get it. The correlations here look at mood disorders and anxiety disorders. And so what we see is that when combined, people that have a substance disorder and then a mood disorder, that puts you at a much higher rate, for problems with psychological functioning. And it's higher with mood, so depression, dysthymia, bipolar disorders, than it is with the anxiety disorders. Again, another chart, separate study, this is from 2004, just shows that in the past year, did you have a MDE, major depressive episode? And then the red suggests use of alcohol in the past year. So if you had a major depressive episode in the last year, your rates are up by about 10% ballpark to have depression. Another comparison that went across 7 or 8 disorders just shows the yellow bar is your average, people that just have a abuse or dependency diagnosis, and then the rates of these people were there any other factors that contributed to that. So with mood disorders, it goes from about 10% to 21%. Any anxiety disorder, almost the same. And then they break it down to depression, mania, panic attacks, etc. The other common co-occurring disorder is what we would call conduct disorder. And there are specifiers around that, but it basically says, in most males get this diagnosis as opposed to females, do people do destructive things while they're using? Okay, so it can be breaking and entering, it could be running away from home, destruction of property, stealing, etc. And there are limited factors that this doesn't have to be a permanent diagnosis, but often what you'll see is that someone who is deteriorating because of addiction is also going to have what we call a conduct disorder, or at least oppositional defiant disorder, where there's chronic problems in the home. I want to spend my last few minutes getting to some solutions here for you, though. The risk level in terms of suicide rates, and this is older data when I look at 2001, 6.2 times greater risk than the average person if you have an alcohol or drug use disorder. Okay, and it could account for overdoses, purposeful or accidental, or that people turn to drugs as a form of suicide. Okay, that may be the easiest way for them to access the means. Okay, so ultimately, it's not always drugs relates to mood disorder, relates to suicide. We have to also factor in childhood abuse, family history of suicide, and a lot of other factors that get complicated here. But what we find is that when alcohol or drugs are in the picture, the likelihood of other disorders, depression, anxiety across the board is higher. It's higher by anywhere from 4 to 10%. So potential symptoms of drug abuse: changes in mood, anger, irritability, problems in school, rebelliousness, changing groups of friends. Okay, now typically when people begin to use, I say seriously, they pick people that use the same way they do or use more than they do, because that's a way to alibi yourself that, well, gosh, I hang out, but I don't do at least this, so I don't have to look at myself. Dropping out of activities, hygiene, personal care. If you find alcohol, drugs, or paraphernalia on a young person's things, that should be a big red flag. If you smell alcohol on their breath, you smell marijuana on their clothes, red flag. And then clearly all the different signs of intoxication. It doesn't mean necessarily that if you experience these, they're a drug addict, they're an alcoholic, etc. I know that's a hard concept for people to get, like how could a teenager be an alcoholic? But it happens. The primary interventions, again, like suicide, you got to be able to talk to your kids about drinking and about alcohol and alcohol's role and what that's about. If you drink, you've got to drink responsibly, because it goes to that old staple of, if you say, don't do what I say, or do what I say, not what I do. Behaviorally, if you're modeling, this is the way that you can really drink, you're giving them a mixed message. Serve as a positive role model. Don't make alcohol available to them. Get to know your children's friends. Have regular conversations, communicate about it. I think it's okay to share your experiences, especially if you can tie in, like, here were the negative things I experienced, or this was the role. If your life has been touched by alcohol, or if you had an alcoholic in the family, or you've known someone, tell those stories too. Like, make it real. Connect with other parents about, we're going over to a party at Jimmy's on the weekend. Well, what's going to happen there? Okay, is there a chaperone? Who's watching out? Supervise parties, and then encourage other meaningful activities. What I have for you is a list of referrals, and on one side, one part I have referrals for substance abuse, and the other side I have referrals for mental health. Now these are for inpatient, so if you're in crisis, these are the places to go that are in Oakland County. I want to also give you, if you're looking for outpatient, you need some counseling, therapy, etc. mhweb.org is a great place. You look at the county, and they give you lists of sites that provide, tell you what kind of treatment to provide, their hours of operation, and the whole 9 yards. The last thing I want to end with, and it's just really a few sentences. If you want to increase the odds of your child getting well, if it's an alcohol problem, a drug problem, a depressive problem, family involvement is crucial. Statistically, anytime you have family involvement in treatment, you tend to get better results. So that means that even though parents will go, oh, well, but he's the problem, he's doing all this crazy acting out behavior, if you get involved in therapy, that raises their odds, okay? That no one gets sick overnight and no one gets healthy overnight. So go to the groups, talk with other people, get yourself some mental health treatment. Okay, that's all I have. Thank you.
Thank you, Dr. Blackstock. I'll introduce myself. I'm Police Chief Chuck Nebus from Farmington Hills. And Dave, if you're awake in the booth there, if I drink water, I want you to cut the video. If you saw the State of the Union last night, you know you can't drink water when you speak. And if you didn't see it, you can watch Jay Leno or David Letterman tonight, and they'll probably be talking about it. What we started in Farmington Hills here is contagious. Last week I was in Florida and I Googled the topic substance abuse, mental health, and suicide, and it wasn't a big help because I got us. I got our press release and our information and stuff about our task force. And then I went into the email, and Commander Matt Kane sent me an email in the Royal Oak paper. Dr. Ken Massey, our councilman, was in there, appearing in Royal Oak because in, I think it was a 5-month period, they had 2 suicides in an attempt at either their gun range or a gun shop in their city. And I went on an email and saw a police officer in Texas who was doing something similar, and I read all about that, and it was a kind of something spurned from here. And on the weekend, I got back after an 11-hour flight, thanks to snow and computers out in the airplane, to the community. And I don't know if it's Gala or Gala. I'll ask our newspaper folks here. Is it Gala or Gala?
I say Gala.
Gala? All right, we talk about that at the staff meeting all the time. Whatever it is, the community gala. A very prestigious award went to Catherine and Dr. Ken Massey. We're the recipient of the 2013 Riley Award for Altruism, and I just thought that was worth mentioning for a minute. And very proud of you, Ken. And Ken got up and gave a speech from the heart, and it was very overwhelming. And I'd like to ask, too, if Dr. Randy Bruce and Nancy Bates, could you just stand for a second and let everyone see who you are? And these are the folks with Dr. Massey who started all of this in Farmington Hills. It was back in 2010 that this all started, and those 3 council members contacted me about some statistics and things, and they said, we're not going to have this in our community, and this all has been growing out of that. We've had weekly updates they've been asking me from, and I'm glad that they care. It lets the officers care. I talk to the officers about mental health issues. We make it important in our community. It's led to all these community conversations. We've had exposure with the Michigan Municipal League, the National League of Cities, all over the place. Ken mentioned the resolution council did. We're proud that you did that to Governor Snyder and the mental health to folks and to ask them to ensure the safety of our citizens and protection of the community and make mental health a priority. And why all this? Maybe just a quick look back at 2012. We had 7 suicides last year in Farmington Hills. The year before we had 10. Last year we had 92 people attempt to take their life in Farmington Hills. We had 81 other people who threatened to take their life in Farmington Hills last year. Our police officers petitioned 230 people for mental health treatment last year, which was an 18% increase. People sometimes ask me, they say, Chief, what's the biggest challenge you have in Farmington Hills? And they usually expect me to say crime or some kind of crime. They're a little surprised sometimes when I come back and say that the biggest challenge we have is mental health issues. And maybe an example of that to make a point is I saw a statistic recently that there's 100 suicides a day in the United States, and that's double the average number of murders. And it made me think a little bit that we have sometimes no murders in Farmington Hills, sometimes 1 or 2. We probably average 1 or 2 if you did the averages over the year. But I know as chief, when we start a year, if history repeats itself, I know we're going to lose 7 to 10 people that live in this community from suicide. And is there a relationship between substance abuse, mental health, and suicide? A brochure tonight says the risk factors are 3 times as high. I would tell you it's probably way higher than that. It's just sometimes can't be measured. I took a peek at 2012, the 7 suicides I mentioned that we had, and I want to go through them briefly, just 5 of the 7, and I'm going to be very careful not to mention genders and ages, and I will just tell you it involves people, like every year, from young people, middle-aged people, to elderly people. But I want to make sure I'm very sensitive. But one of the incidents last year, it involved a gun, it involved drugs, it involved hallucinogenic mushrooms, it involved alcohol that night. The person was on probation for an alcohol offense. Another situation involved someone who took their life by hanging. The person had 20 police contacts. Most of them were for substance abuse and alcohol. Another person was depressed over the loss of a loved one who ironically accidentally died from an accidental drug overdose. Another one, there was a suicide note, a history of drinking, and an empty vodka bottle next to the body. Another one, there was a person who took pills and consumed alcohol, and there was a note, and the person was about to appear in court for their second OWI offense. And the other two, I don't know, but there was nothing for sure that I could say. So is there a common denominator in all those 5 cases? And the answer is yes. Substance abuse plus depression equals suicide in all those particular cases. The point of my message, and it's going to be brief, I'm not going to go just a moment or two longer, but it's to create awareness and education that substance abuse plus depression can equal suicide. If we're educated about the issues, if we're willing to talk about it, and if we're observant to all the warning signs, we have a chance to save lives. If you think my message is simple and everyone gets it, I'm just going to close with a couple of real quick stories, because it isn't always obvious. Sometimes we deal with victims or families and they look back and I think, Ken, are the magnets available, did I hear you say? The magnets, are they on the table out there? So it's something that you can take with you. So a couple of quick stories, and these are not cases from last year. I picked a case that's a little bit older, and I want to be careful again, but there was a death by a hanging. The person had a history that was known to the family about depression. They had found a rope hanging in the garage with a noose on it before this had happened. They saw some Googling that was taking place about someone looking at suicide. So when you see those kind of signs, you have to act on them. Another situation involved a person who was known with a substance abuse problem. They knew the person was depressed. They knew the person had been drinking all day. They dropped the person off with a bag and a helium tank. So substance abuse plus depression may equal suicide. We have to be alert for it. We need to educate. We need to observe the warning signs. We need to talk. We need to remove the stigma. We need to work toward making suicide preventable. Spread the word. Thank you.
Good evening. My name is Bob Schultz. I'm the director for Farmington Public Safety, and unfortunately, fortunately, we don't have quite as many incidents in the city of Farmington, but we're also quite a bit smaller. But proportionately, we also are seeing a fair share. I can remember being a young officer 25 years ago, having to do with mental health issue and maybe somebody trying to commit suicide, and we would have to actually go back to the station, usually look through a book, find out how to fill out the petitions, and then take somebody to the hospital. It has gotten to the point today the officers can do it out of memory. They do it so frequently. It is definitely an issue that we deal with as far as mental health. And we petition people when we feel they're going to be a threat to themselves. So again, in the city of Farmington, we're doing that at least 25 times or more a year. For us, the majority of them are adults, probably 75 to 80% are adults, the rest are juvenile. Same thing in the city of Farmington. There is no particular race, color, sex. It runs the gamut. The one thing I did find, it seemed to be a common factor for those who actually did overtly try to hurt themselves. There was either some type of drug use or alcohol use, but there was an underlying factor of either problems with work, problems with the relationship, problems with finance. So the combination always seemed to come together and be a breaking point for them. So the 38,000, I would actually indicate that could be higher. I don't know how many times first responders go to single motor vehicle accidents in the middle of the night where a car leaves the expressway and hits a bridge abutment. A lot of times we contribute that to a car crash, but we probably know many of those could be suicides too. Drug overdoses, how many of those are intentional inflictions of too much narcotics where medically they get classified as an overdose and they're actually suicide. So this number could actually be quite a bit higher in the end. I guess a good thing, and we talked about getting help in part of this. Each year, though, we are seeing an increase in the number of families who are coming to us who have went to the court. If you know of a situation, you as a loved one, if you can't get somebody to voluntarily go get help, you can seek help for a loved one. Go to the probate court in Oakland County, Wayne County, wherever you reside, or that individual, and you can get a petition to have them committed or taken to a mental health or hospital to get treatment and help them. So we're seeing a rise on that, which is maybe a result of this type of coalition or activity, but either way, we're starting to see a rise on that. This also has an effect on the first responders. Individuals, as tough as we are on the outside, when we see death and suicides regularly, it starts to take a toll on the first responders too. So it has an effect on everybody, not only the family, but those who have to come and help. So Dr. Massey talked about not using the jail as a mental health facility. I will be glad to tell you that in Oakland County, all the police agencies have a jail diversion program, so that if we are dealing with an individual who has committed a crime, but we really know the underlying factor of their activity is mental health, there are many organizations there that we are able to work with, and we're able to divert them. We can get them signed in, and instead of taking them to a jail, we're able to get them into a mental health treatment. So we've been using that for many years, and the county has definitely seen a reduction in the amount of inmates as a result of that type of activity. So, and again, with that, I guess I will leave you with this. Just, I will challenge each and every one of you to talk to one person about suicide. I've talked to my kids, not that I was worried about them, but just as a result of this, we spoke about it. I have one of those magnets hanging right on my fridge at home. And, you know, we just, for them, their family, or their friends, anybody, just as a reminder, and it's okay to talk about it. So again, I will challenge each of you as you go home, at some point in time, talk to one person about it. So, thank you.
Well, good evening. I'm Judge Marla Parker. I'm a judge in the 47th District Court for Farmington and Farmington Hills. I also want to congratulate this group. This is an important subject to talk about, and I'm so glad to see so many people here willing to listen and to do what they can. Also, congratulations to those who started it, Randy Bruce, Ken Massey, Nancy Bates, and also congratulations to Drs. Ken and Catherine Massey for receiving the Altruism Award from the Farmington Hills Foundation for Youth and Families, and that was in part, in great part, because of the work they've done with this organization. As a judge in our community, we see a significant number of people involved in the justice system that present themselves with mental health, alcohol, and drug issues. It's been a pretty common statistic that's been bandied around that approximately 60 to 80% of people in jails or prisons have substance issues. In most, particularly in the prison system, it's not like they're getting treatment for that. So when someone is sentenced to jail or prison with a problem, mental health or substance issue, they're likely to come out with those same problems. And what we see sometimes is almost warehousing. And I'm glad to see that there are, particularly in the Oakland County Jail, we've definitely seen some improvements in working with treatment and diversion programs. As a judge in our court, we are seeing more and more mental health issues either that go untreated or people who are not following a treatment regimen even if they have been treated. We are seeing people that maybe don't belong in starting with the justice system, and we see them not only in substance abuse issues, whether drug or alcohol, but also assaultive cases, disorderly person, family issues, domestic violence, and much of that is related to mental health and substance issues. And obviously, I'm pleased to see that there are many who are encouraging the establishment of greater resources. But we are fortunate to be in a community that does have resources. And one of those resources happens to be at the court. I can't help but noting the chief's comment that there was in the past a suicide for someone who was worried that they had gotten arrested for a drinking and driving offense, and they were afraid of going to court. I will say this: I don't encourage anyone to get an offense to come to court, but court sometimes can be a solution. And one of the solutions we have in our court is called the Sobriety Court Program. And this is part of a theory of specialty courts that have sprung up around the nation. These courts are very data-driven. We take a look at research to determine how the programs should be established. And we'll start out by sharing that the mission of the 47th District Court Sobriety Court Program is to protect society and reduce crime by targeting substance abuse and addiction through intervention, treatment, and offender accountability. Basically, people who are convicted of drinking and driving offenses who meet certain criteria are placed in the Sobriety Court Program. And those criteria basically are they're a resident of Farmington or Farmington Hills, have a conviction, are convicted for drinking and driving, have either a blood alcohol content of 0.15 or above, or a prior alcohol or drug offense, or a substance abuse assessment indicating that there is a serious alcohol issue, whether it's abuse or addiction, or the discretion of the sobriety court team. If the person meets those criteria, they are placed in the sobriety court program. To start out by saying that some of the research that's been developed shows that the sooner you can get someone into treatment, the more likely it is to be effective. So one of the things about sobriety court is that we do try to get people into court as fast as possible to address the legal issues as quickly as we can to determine if in fact there is a conviction, then we can get them as quickly as possible to the treatment component. But one of the things we also know about treatment in general is that, well, let's step back. I think we talked first about you send people to jail, they come out of jail, they haven't changed. And I know that probably the gut reaction that most people have when they see a repeat offender, drunk driver, is that person ought to go to jail. And that may very well be true. But what we know is that when they come out, maybe if they don't have any treatment, probably the first thing they're going to do is have a friend meet them, pick them up at the jail, meet them at the door with a bottle of alcohol, and they're going to go right and drink. We also know that people who enter into treatment voluntarily, sometimes it's hard to follow through, and I'm sure everyone here has made a New Year's resolution or two that you start out at the beginning of the year that you're gung-ho, but as the year goes on, maybe it's not so easy to follow through. One of the things about sobriety court and the concept of specialty courts is that we can hold people accountable to keep them into treatment long enough for it to work. And that's one of the beauties about sobriety court. So what sobriety court really is a system of incentives, sanctions, requirements that have been shown to be effective in addressing people with alcohol and sometimes drug issues, but they've usually gotten to court on a drinking and driving offense. What the program involves is requiring everyone in the program to be on a 24-month probationary period that's 4 phases. In the first phase of the program, someone in the program is testing for alcohol twice a day. They're being random tested for drugs. They're required to participate in outpatient or some form of substance abuse treatment, individual and group. They're required to attend 12-step support group meetings, things such as AA or NA. They're required to attend meetings with their probation officer. We have a group called the Phoenix Group that is made up of all of the members of the sobriety court who are currently in sobriety court or who have graduated as another area of support and encouragement for the newer people to make it through. People are doing something for sobriety court every day. Particularly in the first phase. And one of the things that's very different about the sobriety court program than a standard probationary period is that when you're placed in sobriety, when you have a standard probationary period, I might sentence someone to something and I might never see them again unless they violated or had a problem on their probation. But in sobriety court, we start out by having the people come back to court every 2 weeks for a court review. So I really get to know the people who are in sobriety court. And before they come to court in their court review, each of their cases is reviewed with a sobriety court team that consists of a judge, the sobriety court coordinator, probation officers, a treatment provider, a defense lawyer. We all meet and discuss each case to determine what has happened with that person from the last time they were in court to the date that they're about to come see us again. And we take a look to see, have they done all of their testing? Have they made all their probation appointments? Have they tested negative? Have they gone to all their meetings? Have they provided proof? If they come into court and they've done that, we applaud them and encourage them. If there is anything that they have not done, we sanction them. And the sanctions could be up to including jail, but it could be doing some community work program. It could be ordering, sometimes we've had some problems with people just getting their life organized, and we've had them attend various life skills programs. So our goal really in this program is to be really intense at the beginning, to get people sober. The second phase, there are fewer testing, a little bit less often, more on a random basis. We have some other programs that we have them attend, and we're really basically, first phase is getting them people sober. Second phase is really, all right, how are you managing and planning your life and stabilizing to make sure that you're maintaining sobriety. Really, we get to a third phase, and we're trying to address issues in those people's lives, because often people are drinking because they have problems with their finances or problems in family relationships, or so we address issues of education and financial education and issues to get people on track. And finally, there's a fourth phase, which is the life phase, which basically we're saying now you have all these skills, you've made a plan, and we require everyone to do a relapse prevention plan that they can refer to then go on and show us they can manage that with a limited amount of court supervision, so that when they're done, what we're hoping is that we have now developed habits and patterns for a long-term life change. We were looking at some local statistics to take a look at how successful we've been, but in those statistics, we've gotten a little bit of a look at it. It's wonderful to see what a difference it makes. I think I'm not going to quote some local statistics because we found an error in the statistics, so I don't want to be misquoted. But I'll tell you, as far as some Michigan-wide statistics of recent years, you find that approximately 30% of people who are arrested for drinking and driving in Michigan are repeat offenders. 60 to 80% of those will offend again. But in the statewide sobriety court graduates, only 12 to 17% will offend again. So it makes a huge difference. So we really are successful in dealing with people who have issues of drinking and driving, and I think there are a lot of reasons why this works. I think we've stated some of them, but in taking a look at what some of the anecdotal issues when people present in front of us, and we really do get to know them, it is amazing how many of the people come before the court feeling alone. And I have had so often, our team talks about how people are so much happier in the sobriety court program because they have a team of people who are supporting them, other people in the program going through what they're going through. They're attending 12-step meetings, obtaining a sponsor and a connection, and really reestablishing a life that they didn't have, so that we're almost mandating them to have the social support that they really don't have, that they were masking with drinking. And those are some issues, as we know, that are potential issues with regard to suicide. I know that people, as I said, are afraid to go to court and afraid of consequences, and we want them to be. On the other hand, more than one person has come before the court at the end of their sentence saying, my life was horrible. I was thinking of ending my life. I was drinking all the time. I prayed for a solution to my problem. Little did I know the solution was going to be being arrested for drunk driving, and that has given me a life that I never thought I'd have. We have had members who have been in our sobriety court where there have had previous attempts at suicide, but Yet, again, now we see people who are going through the program who say now they have a reason to live, they have a support system. Many positive comments of, I can exercise now every day, I'm not hungover, I remember where I am when I wake up in the morning. So there are a lot of things that happen with the sobriety court, but overall it's been an amazingly positive experience, and for me it's an inspiration to see that we can really make changes in people's lives. I'll mention that the sobriety court, after a person's graduated the program or finished the program, we actually hold a graduation that we open up to the public, and people invite their families and friends. We have receptions, and we generally hold our graduations either in this room or at the City of Farmington City Hall. And if you ever would want to attend a graduation, you're certainly welcome to, because it really is inspirational to see that some people who may have given up hope now have hope in their lives. And so often what we're also seeing is how many of the people who have graduated the program are now giving back to others, that they come back and attend the Phoenix group meetings after they're not required to come back to court anymore. They'll come participate in the group. How many of them stop by our probation department just to give an update, or stop in court when they know we're having a sobriety court review just to say hello and report what they're doing. And we've had some of them who have spoken at public forums or at our graduation ceremonies talking about how their life in the long term has changed. And I will say that I can't say that we've gone through never having had anyone have a repeat offense. We have, but we went through more than 5 years not one graduate got a new offense, and it is amazing to see how people change their lives. We take pictures of people when they start the sobriety court program. We keep them in their file. We take a picture at the end, and it is amazing to see the changes in people, just the expressions on the face, the relief in their life, because now they are part of a support group. I'm going to encourage that to say that probably the biggest thing that will help any person in crisis is support from others, to let them know that there are people that care. And often I've gotten comments from family members of graduates from sobriety court saying, my son, daughter came out of sobriety court and said, this judge really cares about me. These people on the team really care about me. I know people in this community, we really care about others, so hopefully we can use this as just one of the many programs to show that we care and prevent any future tragedies. So I thank you for those comments.
Good evening. My name is Mitch Seeley. I'm on the board of the Oakland County Al-Anon, Alateen, and also the Farmington Hills Call to Action Coalition. And I also want to thank the task force here for putting this program together. I want to talk about what it's like to live with an alcoholic or a drug abuser, and I happen to live with both. You live in constant fear of what's going to happen today. When I got physically tired, a good night's sleep, I'm ready to go the next day. When you get mentally tired of dealing with this disease, you never get a good night's sleep. You wake up and you're exhausted, and the fear kicks in. Is today the day she's going to kill herself, drink herself to death? When she was a couple hours late coming home from work, church, wherever, your mind runs rampant. Is she in an accident? Has she hurt herself? Has she killed herself? Or the worst fear, has she killed an innocent person? And what should I be doing to stop this deal? If I was reading a golf magazine, a paragraph, I couldn't tell you 2 words I just read. Watching TV at a commercial, I couldn't get back to the program because I didn't know what it was. My mind was spinning, what's going on? Where is she? What's the issue of the deal? If the phone rang during this period, your heart just jumped. The police, the hospital, the morgue. And God forbid if you heard a siren, So I come to Al-Anon because I wanted to fix this issue. My parents taught me when you had a problem, you had a tough decision to make, grab all the information you can be objective, look at it from all sides, and then make the best decision you can. And in most things in my life, that principle's worked very well for me. But with alcohol and drug abuse, there's no logic from the addict side. You know, what I saw was black and white and crystal clear. The addict sees gray and fuzzy and denial. And I was just beating my head against the wall. How can she not see what's happening here? You know? The most important thing to an addict is where's my next drink and how fast can I get to it. Nothing else matters. Communication goes out the relationship. Lying comes into it. There's no trust. And without trust and communication, you don't have a relationship. So I came into Al-Anon, and all I want to do is get the things of how to fix this problem. And Al-Anon is for the families and the friends of alcoholics. And you got to take care of yourself first. I said, well, I'm not the issue. The alcohol and drug abuse is the issue in my family. But you become part of the problem. You know, you're so fixated on solving this issue that you're just as wrecked as they are. I'd spend my whole day living in fear. You go through the whole gamut of all the emotions, and you can do it in minutes. You know, pain, fear, happiness, anger, everything. You stop functioning, you know. I used to be a great multitasker. You couldn't throw enough things at me that would frustrate me. I'd wake up and I'd have 20 things to do today. At the peak of the alcohol and drug abuse in my home, I'd get 2 of them done. The next day I'd have 20 more, plus the 18 I didn't do yesterday. At the end of the week, I'd have 80, 90 things I didn't get done. I'm never going to get them done, so I'd throw them in the trash, and I'll catch up next week. You went through the same deal again. You end up thinking with your heart, not your brain. I was constantly complaining about the past, worrying about the future, that I forgot to live today. Step 1 in Al-Anon and AA is admitted you are powerless over alcohol, and in your life it become unmanageable. Well, I knew my life was unmanageable before I went to Al-Anon, but to admit I was powerless over something, not in my vocabulary. As long as you kept trying, keep plugging away, kept working it, you know, I was going to get to where I wanted to go. I just couldn't do it with alcohol and drug abuse. When people come into Al-Anon, you ask, why do I have to do anything? I'm not the issue. I'm not the alcoholic. But it's amazing how it affects every part of everyone's lives in this deal. You live in fear. I was talking to a lady who came 2 weeks ago for her first meeting. Why do I have to do anything? You know? But meanwhile, she's telling you, I can't go to bed till 2 or 3 o'clock in the morning because my son will call and I got to go pick him up. You know, he sleeps all day, he parties all night. She's always, same as I was, always worrying about what was going to happen. Al-Anon will teach you how to put down boundaries, you know, and how to live with this disease. The Al-Teen program is for teenagers, and when they come in, their self-esteem is completely beaten up, mostly because they have a parent who's abusing alcohol and drugs. They are afraid to have anyone over, any of their friends over their house because of the chaos of what this disease does. They think if they got better grades, if they were better in sports, if they were taller, if they were thinner, if they were this, you know, my mom or dad or whoever would stop drinking. One of the deals that the Al-Teens amazingly tell me is after they've been in a program a year or two, their other Al-Teens people are their best friends in life. They're the only people they've ever been honest with. You know, you're afraid to talk about this disease. If I tell people I got cancer, I got a heart condition, this audience can't wait to tell me about their doctor. When you mention a mental illness, I don't know anything about this. And when I first tried to get help with this deal, I asked one of my closest friends, you know anything about this? And she said no. And I was just bumfounded because 6 months earlier I went to her sister's funeral who died of alcoholism. But she wasn't able to talk about it. Since then, you know, I was working the program 9 months, almost a year. She told me not only did she lose her sister, her father died of it, her one brother got a liver transplant, Her other brother's waiting on the list for a liver transplant. It just runs rampant in her family, and yeah, we keep this thing in the closet way too long. And we try to teach the Alateens to love the alcoholic, but hate the disease. You know, their body cannot process alcohol like a normal person does. There are many slogans in Al-Anon. One is the 3 C's. You didn't cause this disease, you can't cure it, and you can't control it. Going to seminars, you know, you listen to the AA people talk. Most of them could do stand-up comedy of just talking about the crazy things they did when they were under the influence. When you listen to an Al-Anon person talk, you get to hear all the fear and the hurt that they went through living with an alcoholic. This is, without a doubt, the most frustrating thing I've ever been thrown into, because there is no logic from the alcoholic. The one thing you'll find when you come to Al-Anon, you will find hope. Before, I felt like I was falling in a dark hole where there was no light, and I did find light at the end of the tunnel. I met a person, I've been in the program 8 years. I met a person 7 years ago that went through rehab herself 18 times. But she goes, Mitch, I only did it once for myself. And I said, what caused it for you to stay sober the last time? Is I looked in the mirror and I knew one of 3 things were going to happen to me. I was going to get help and get in a recovery program. I was going to get locked up, either in jail or a hospital, or I was going to die from this disease. And people do die. We sponsored a talk at Huron Valley Hospital in December, and we had an Alateen person talk there. This was the first weekend in December. Thanksgiving weekend, Saturday, was her 16th birthday. She got a call from her father. He was incoherent, and the only thing she could understand was gas. And she figured he was buying gas somewhere for his car. She drove to 3 gas stations, finds him, he's passed out. He left a suicide note. And the way he was going to do it is he swallowed razor blades. And this poor girl, and he wasn't successful, but his internal plumbing will never be the same. But this poor girl, this guy would have let his daughter look forward to every one of her birthdays in the future and think, this is the day my dad did this. And just an ungodly way to do it, in my opinion. There's no good way to do it, but this thing just brought everyone to tears of the deal. It's the ugly, ugly disease. And, you know, I did everything I could to try to fix this deal, and I couldn't. Admitting you were powerless over something took me a year before I finally waved a white flag and surrendered. So there are packages out in the lobby to take home with you, and I'll be after the meeting. I'll be happy to talk to anybody. Thank you.